Dr. Anuradha, this is Dr.
Hello, ma'am. Good evening to all.
Anuradha, welcome.
Thank you, sir. Good evening.
Dr. Jayanti, you can start.
I can start the program. Okay. Good evening, everyone. On behalf of our chairman, Asian Institute of Gastroenterology, Dr. Nagesh Reddy, our course director of IBDENC, Dr. Rupa Banerjee, and my co-moderator, Dr. G.N. Ramesh, I wish you all a very happy new year. We start today's first session on IBDENC this year with multi-speciality involvement on management of IBD beyond the gut. We have speakers across several specialties. We have the first slide, which is linked with inflammatory bowel disease. I have the introductory slides, please. Dr. Amita Agarwal, oncologist, speak on arthritis and joint involvement in IBD. Dr. Ali will be speaking on his perspectives in this topic. Karthik will be highlighting on the various thromboembolic complications of inflammatory bowel disease. Dr. Anuradha, who will discuss about the skin involvement in patients with IBD. And Dr. Natasha on ocular involvement. The habitability manifestations will be dealt by Dr. P.N. Rao. The gastroenterology perspective by Dr. Ranga. Before we move on to the specific sessions, that's the academic session, I request Dr. Nagesh Reddy to give his welcome address to them. Over to Dr. Nagesh Reddy.
Good evening and welcome to another session of IBDENC. Every month, these sessions of IBDENC are becoming extremely popular, not only in India but all over the world and in emerging countries. Every time we have one specific topic which is spoken and of course a specific country which is highlighted. Unfortunately, with this new third wave, the Omicron wave, we are not able to have physical meetings or more open meetings. Hopefully, this will be resolved soon as this third wave seems to be coming down rapidly. But for now, we have a very interesting topic for this time on IBD beyond the gut. IBD involves, we know, several other parts of the body, and of course, the discussions are going to predominantly on these organs which are beyond the gut, which are affected by patients' inflammatory bowel disease. And hopefully, we'll have another good session again. Thank you.
Thank you very much, Dr. Nagesh Reddy, for that, for those words of introduction. I'll quickly come into the topic, and it's my pleasure to be one of the moderators. Thank you very much, Dr. Jayanti. We are going to discuss about extraintestinal manifestations, and it's important for us to realize that IBD involves very often, involves organs outside the gut as well, and it's quite common with figures as high as 20 to 40% in Crohn's and 15 to 20% in patients with ulcerative colitis. What is even more important for us to understand is that the probability of developing extraintestinal manifestations increases with disease duration, can occur at any time of the disease, can often predate the disease also, and may or may not correlate with disease activity. A lot of organs can be involved, but it's important for us to understand that there are some manifestations that parallel the disease activity. There are some that do not parallel the disease activity, and there are some which may or may not parallel the disease activity, and that also will be the focus of discussion today. I think the important thing for us to understand is that in 1/4 of the patients, extraintestinal manifestations may predate the diagnosis of inflammatory bowel disease, and this is something that is very important for us to understand, besides, of course, the fact that we still have not understood properly the pathogenesis. So with this brief introduction, I would like to invite the first speaker of the evening, very noted rheumatologist, a friend for many years, Dr. Amita Agarwal, and she was going to talk to us about arthritis, arthralgia, and spondylitis in patients with IBD, what to do. Over to you, Amita.
Thank you, Dr. Ramesh, and I'll just share my screen, and I hope all of you can see it.
Yes, we can.
Yeah. So, and the title is interesting, arthritis, arthralgia, spondylitis, what to do. So you know that there is lots to do in this area. And as Dr. Ramesh said, that extra-intestinal manifestations are pretty common in patients with inflammatory bowel disease. And if you see, you have a host of them. But among them, the most common are arthritis. And arthritis occurs in about 70% of patients who have extra-intestinal manifestations. And this is the data from the Toronto cohort, where almost 1/3 individuals had extra-intestinal manifestations. And the two most important joint manifestations are either peripheral arthritis, which is seen much more often, or you have a disease which involves a vertebrae, which we call as axial arthritis. And this is, again, the figure which Dr. Ramesh had shown you. And we all, as he's told you, that about 1/4 of them, extra-intestinal manifestation can predate the onset of inflammatory bowel disease. So it's not that the gastroenterologist have to be aware of rheumatological manifestation. The rheumatologist also needs to be aware that sometimes the joint manifestation can predate a bowel disease, when to think of it. And it's also important that if a patient has one extra-intestinal manifestation, the patient can have multiple extra-intestinal manifestations. So if you have a patient who comes to you with arthritis and you think that the patient has inflammatory bowel disease, you need to do a full review to find out, does the patient have any past history of other extra-intestinal manifestation which can occur in a patient with inflammatory bowel disease. So the patient doesn't know that these things are linked. Unless you take a detailed history, you may miss out on that. So when do we think of inflammatory bowel disease if a patient comes with arthritis alone? So if a patient has axial spondyloarthropathy, but you find the weight loss is out of proportion to the degree of inflammation, or anemia is out of proportion to the degree of inflammation, you would always like to exclude inflammatory bowel. There's no better way to learn than from patients. So this is a patient whom we saw very recently. He had a history of about 6 years. In 2015, he had diarrhea which lasted for 2 weeks. That was associated with fever. He had right knee arthritis, which was treated with intra-articular corticosteroids, and he was also given methotrexate. His symptoms improved within 2 months, and he stopped all his therapy after 6 months. In January 2020, he had left knee monoarthritis, again associated with diarrhea. This time it resolved in 4 weeks. In December 21, when he came to us, his illness started about 6 weeks ago with right knee monoarthritis. And simultaneously, he started having loose motions, fever, and the investigation showed that he had leukocytosis. This time, his things didn't resolve, and the joint manifestation kept on increasing. He had gradual involvement of left knee, both wrist, left ankle, and he had morning stiffness, which was lasting about 2 to 3 months. So when we saw him, we thought there are two possibilities. One is that he's having recurrent reactive arthritis, or he had IBD-associated arthritis, since he has involvement of bowel and joints simultaneously. His investigations revealed that he had anemia, he had leukocytosis, he had elevated ESR and a CRP, and a lowering of albumin, all suggestive of significant inflammation. So we thought of IBD with arthritis, and the first thing we did was CT enteroclysis, which showed that he had circumferential hypodense wall thickening and multiple features which suggested that he had features of Crohn's disease. The colonoscopy done also suggested a diagnosis of inflammatory bowel disease, and the biopsy showed cryptitis and infiltration by mixed inflammatory lymphocytes, plasma cells, neutrophils, and there was no evidence of any other infection. So thus he has IBD with arthritis. This is a story of another patient who was an 18-year-old boy who had a history of 2 years. He had inflammatory back pain. He had heel pain for 1 year. He used to get treatment with NSAIDs off and on. And for the last 2 months, he was having fatigue, feeling not well, dyspnea on exertion. And this time he was found to have a severe anemia. He had no bowel symptoms at all. He had no history of erythema nodosum, no history of uveitis, no skin lesions. On examination, he had severe pallor. He had restricted forward flexion of the lumbar spine. He had bilateral hip joint tenderness and also had bilateral tenderness of the tendoachilles. So he had a picture which is like spondyloarthropathy, but he has severe anemia. In a male, if you get this degree of anemia, in this setting, we would always like to exclude spondyloarthropathy. And if you see, he has a hemoglobin was 5.5, he had thrombocytosis, which can also occur in iron deficiency anemia. He had high ESR, stool occult blood was positive, he had a high stool calprotectin levels, and colonoscopy and colonic biopsy confirmed the diagnosis of ulcerative colitis. His X-ray showed that he had grade 2 sacroiliitis and he was also HLA-B27. So in this boy, we did not have any evidence of bowel disease on history, but only on investigations, we have found that he had subclinical bowel disease. So how common is joint disease and inflammatory bowel disease? The figures vary depending on do you include arthralgias or not. If you include arthralgias, it is about 40 to 50%. If you take only severe arthritis, it is about 6 to 10%. It's much more common in younger individuals. So it's been shown that in individuals who are less than 25 years, it's about 25%. And older individuals have a lower prevalence of arthritis. And the prevalence is a bit higher in Crohn's disease as compared to ulcerative colitis, but it's not greatly different. It's also been seen that if you have colon involvement in a setting of Crohn's disease, the chances that you have a peripheral arthritis is much higher. And this is based a classification which was based on a large data set where people thought that there are 2 different kinds of arthritis which are seen in inflammatory bowel disease. This is type 1 or oligoarthritis, that is generally you have 4 or less joints involved. It's an acute presentation. It generally goes hand in hand with the bowel activity, as Dr. Ramesh showed you that there are some features which go along with bowel activity, and this is one of them, and usually resolves within a matter of 6 to 8 weeks. Relapses are common, as are relapses common in bowel disease, and it has a good association with HLA-ERB10103. While you have more joints involved, it's more likely to be chronic, persistent, and relapses. Because they have a persistent disease, they have less often relapses, and the correlation with bowel activity is not. But recent data suggest that it is a continuum. In the initial part of illness, you may have less number of joints involved. As the disease progresses, it can go on to become polyarthritis. So if you look at the joint involvement, in the oligoarthritis, you generally have involvement of the lower limb joints, that is knee, ankles. While in the polyarthritis variety, it is all across. And plus you have involvement of the small joints of hands. It simulates like rheumatoid arthritis. Why does arthritis occur? None of us know very well, but it is thought that when you have gut inflammation, there is increase in gut permeability, plus there is infiltration by lymphocytes. So either the microbial material can migrate, or the gut educated lymphocytes can migrate to the joint and cause inflammation. And also you have antibody development to these microbial agents. They can form immune complexes, and immune complexes can get deposited in the joint, leading to synovitis. But the exact mechanism why it occurs, exactly not. The other spectrum is the spondyloarthropathy spectrum, where you have inflammatory back pain. Inflammatory back pain means the pain usually starts in the second half of the night. You have significant early morning stiffness. It gets better as the person starts moving. It improves with exercise, and it usually lasts for long periods of time. And these patients may have evidence of sacroiliitis on it. Some patients will have looked at the X-ray pictures which are done, which used to be done when we used to do enteroclysis or bariums for these patients with inflammatory bowel disease. And if you look at the X-rays, Asymptomatic sacroiliac joint erosions or sclerosis is seen on imaging in about 1/3 of individuals with inflammatory. And sometimes you can have inflammatory back pain without any radiological finding. Could be an forme fruste of spondyloarthropathy, or now what we call as non-radiographic axial spondyloarthropathy. Rarely you can have a sausage digit, that is swelling of the whole digit. That is because of dactylitis. Or you can have inflammation at the site of insertion of tendons, what is called as enthesitis. So it can give you a heel pain, pain in the foot, or pain on the lateral side of the thigh. So these are areas where enthesial site inflammation is very common. The sacroiliitis, what is seen in patients with inflammatory bowel disease, is absolutely similar to what we see in ankylosing spondylitis. It is bilaterally symmetrical. It can be symptomatic or asymptomatic. As I said earlier, that asymptomatic sacroiliitis is seen in about 50% of individuals. This is a meta-analysis which shows that the prevalence is about 30%, this meta-analysis. And clinical sacroiliitis is seen in only about 10% of them. And about 5% of these can have mixture of inflammatory back pain and also a lower limb arthritis. So what do you do when you have a patient with joint symptoms? You take a good history, ask them about joint swelling, because just pure joint pains are not that significant to the patient, and we have a different management for them. Look at the distribution of joint involvement. Does the patient have early morning stiffness? Because that will suggest that there is inflammation. If a patient complains of diffuse aches and pains, but there is no swelling, no early morning stiffness, it is more likely that the patient has fibromyalgia, which is also seen quite often in patients. If there is a predominant lower limb arthritis, it is more likely to be a spondyloarthropathy. You ask history for heel pain, low backache, any history of uveitis in the past, and what is the activity of disease. On examination, you look at the joint swelling and limitation of joint movement. You also look at the lumbar spine movements for their limitation, and look at these enthesial site, press on them and see that is there enthesial site inflammation. Investigations, we don't need too many investigations. You can do a complete blood count, look at the acute phase reactants. If it is a chronic arthritis and you're looking at damage or reduction in joint space, which happens very rarely in patients with inflammatory bowel disease, except in the X-ray of the sacroiliac joint, you can look at that. Enthesitis, if patient complains of heel pain but there is no tenderness, you may do a ultrasound, like which is a very routine procedure in our outpatient clinic, where you can see that this is the Achilles tendon, which will show you some amount of edema, and there is a power Doppler signal suggesting that there is increased vascularity. You can also do an MRI if there is a significant inflammatory back pain, which can show you bone marrow edema in the sacroiliac joint on the either side. HLA-B27, generally not required, but if you are not sure that it is an inflammatory back pain or not, and patient is having persistent symptom, and X-rays are normal, then presence of HLA-B27 may help you in making or at least increasing the probability of diagnosis of spondyloarthropathy. How do you treat these patients? Obviously, our aim is to have symptomatic relief, as IBD arthritis is usually non-destructive, and also to prevent relapse. For the patient, pain control is the most important. So, though we know that NSAIDs can sometimes cause flare of bowel disease, but they are generally well tolerated. They are most useful in patients with spondyloarthropathy or enthesitis. There is some data to suggest that selective COX-2 inhibitors like celecoxib may have better tolerance, but other studies show that there is no difference. Generally, we use NSAIDs only for short term. You always keep a check on the bowel activity. If it increases after use of NSAIDs, please stop it. Corticosteroids are useful in peripheral arthritis, but not very good for inflammatory. So what do? We have arthralgias, there is no specific treatment. You need to do counseling, tell them that it will disappear as the bowel symptoms will improve, and if need be, you can take non-steroidal anti-inflammatory drugs as and when needed. If you have few joints involved, you treat the bowel disease, generally it will go into remission on its own. If it is highly painful, you can just give intra-articular steroid into 1 or 2 joints, and that will quieten the joints. only in a very rare case that you need to use anti-inflammatory. If it is polyarthritis, then you use NSAIDs for short term, and then you might need to use disease-modifying anti-rheumatic drugs. Sulfasalazine is preferred when we have a probability of ulcerative colitis, and methotrexate is preferred if you have Crohn's disease because they also have effect on the bowel disease. Even azathioprine, which is used for Crohn's disease, also has beneficial effect on polyarthritis. And if these conventional drugs don't help, then anti-TNF can be used. So if you have predominantly a spinal disease or you have enthesitis, then NSAIDs are useful, but generally you don't like to use it for long term. So the only other alternative left, if there is significant axial disease, is TNF blockers. You obviously educate the patient, ask them to do exercise, have a hot shower in the morning to reduce morning stiffness, and you can give analgesics with paracetamol. But anti-TNF agents have actually changed the life of patients who have predominantly axial disease. For enthesitis, you can use local support, you can give local steroids, but don't inject inside the tendon because otherwise that will become weak. And rarely you need to use anti-TNF agent just for pure enthesitis. And now we have data on ustekinumab, which blocks IL-12 and IL-23. And what it has been shown that it causes resolution of symptoms. Patients who have, it has good effect on the bowel symptoms, and it also has some effect on the arthralgias, because we know that arthralgias and bowel symptoms generally go hand in hand. But effect on ankylosing spondylitis, patients who had concomitant ankylosing spondylitis along with IBD, there was not much impact seen. So we still have to see how good this therapy is. So thus, to summarize, if you have axial involvement in active bowel disease, you do physical activity and use TNF inhibitors, don't use NSAIDs. If you have axial involvement in IBDs in remission, you can try NSAIDs, and if they don't work, you can use inhibitors. If there is a peripheral arthritis and active IBD, if you have few joints, use local steroids. And if you have large number of joints involved, then avoid NSAIDs and use low-dose corticosteroids for pain relief. Then you can try them on sulfasalazine, methotrexate. And if those are not useful, use TNF. If IBD is in remission, then you can try NSAIDs for a short while. So thus, this is what I have to tell you. And then if you have any questions.
Thank you very much, Dr. Amita. That was indeed very precise, very crisp, and at the same time gave us an overview about the arthritis, arthralgia, and spondylitis. At this juncture, I would like to get Dr. Raja from Malaysia into the picture. We've heard Dr. Raja, the rheumatologist's perspective. Of course, she was careful enough to give a very balanced view, rheumatologist as well as a gastroenterologist. Thanks for that, Dr. Amita. Dr. Raja, I would like to know from you your perspective, your experience as far as the spondyloarthropathy as well as the arthritis is concerned. How often do you see it in practice, and do you really often have to resort to things more advanced than steroids and non-steroidal anti-inflammatory drugs for the management? Over to you, Dr. Raja.
Thank you, Dr. Ramesh, for the questions. First of all, a great presentation by Dr. Amita. I enjoyed it. Firstly, the extraintestinal manifestations, spondyloarthritis or arthralgia, is not as common as we see in the West, number one. And a very little data available in Asia-Pacific countries, very limited. And on note, I remember early last year, it's about a multinational 10 or 11 countries look at over 1,700 patients of IBD, and in fact, only it's about 10% who get EIMs. And the first slide that Dr. Amita mentioned, that was Toronto cohort, a very high percentage. But reality in Asia Pacific, ASEAN, or the whole Asia, the EIMs reported very little, 10, 11%. And in fact, less than 1% who may have the multiple EIM to begin with. Now, mostly that we see in practice those who get colonic Crohn disease, and we do not know why actually. And in Asia data, colonic Fracturing Crohn disease, slightly more common in female, we don't know why. And most of the time, the EIM is settled by the first-line treatment of inflammatory bowel disease. You know, if you get axial or peripheral, you get sulfasalazine, somehow the IBD got better, colitis got better, the bone pain is disappeared. So extremely rare if we follow the gut line from any gut line from echo, for example, moderate to severe EIM necessitate anti-TNF. To be honest, extremely rare. In my cohort, nearly 1,000 patients, only 2 patients that I use infliximab for the significant EIM, in this case, peripheral or spondyloarthritis. So basically, is not as common as we said. Majority of the patient, in fact, 95% or above, will responded well when the gut is controlled, and we do not even need to use the biologics much. But the type or the referral from my rheumatological colleagues to the GI is not that common, Dr. Ramesh. And we know that if someone got ankylosing spondylitis, for example, up to 70 or 80% of them has a microscopic inflammation. If we send a fecal capro, they will be mildly elevated, but they may not have a symptoms. And the same thing when we do MRI small bowel, we will see sacroiliitis incidentally without any inflammatory back pain. That's my response, Dr. Ramesh. Back to you.
Thank you. Thank you very much. Thank you very much. I think you have opened up a Pandora's box. We have enough matter to be discussed during the panel discussion. But we now quickly go on to the second talk of the day, and it is over to you, Dr. P.N. Rao. A very common problem. Our patients with inflammatory bowel disease who come to us with an altered liver chemistry, automatically bringing up the suspicion of primary sclerosing cholangitis, autoimmune disorders. How do we surf through that problem, Dr. P.N. Rao?
Thank you very much. Are you able to see my slides?
Yes, yes, yes.
Right. Thank you very much. Thank you, Dr. Rupa, Dr. Jayanti.
You
and
can
Dr.
put it on
Ramesh.
full screen, please.
Is a full screen only?
No.
No, just now I had a rehearsal also.
It is not coming in full screen. We can see the slides nevertheless. You can carry on, please.
Well, then I had some animations also. That's the reason. Just now, just before I had my rehearsal also.
You can actually go down and press onto that right. Just go move right. Move right. That small icon. I can't see your arrow. Go down, go down, go down, go down here. You bring that arrow onto that. Yeah, exactly.
No. That was there only already. That you know.
Yeah,
now
it's
it's
okay.
okay.
Now it's okay. Full
Now
screen?
it's okay. Yeah,
right,
full
thank
screen.
you. Thank you very much. You know, you relieved my tension. Right. Okay. Well, then, I would like to talk about the habitability manifestations and predominantly the altered LFTs. The first thing to occur to anyone is that an abnormal LFT, and these abnormal LFTs are frequent in patients with an inflammatory bowel disease. And in fact, 5% of the patients with an IBD will experience a chronic habitability disease. These, as already been discussed in many EAMs, these may occur at the time of a diagnosis or throughout the course of the disease. But then, abnormal LFTs are very non-specific. Therefore, one has to look for any concomitant diseases. The most common concomitant disease now is NAFLD associated with an IBD, or for that matter, any other disease because of the increase in obesity and diabetes. And specifically, we have to look for an extraintestinal manifestations of inflammatory bowel disease, and not to say the least, adverse reaction to the drug of given for inflammatory bowel disease and also for tuberculosis, because we know that many of our patients, diagnosed in IBD at some stage or other in Asia, will be receiving, or sometimes even concurrently receiving anti-tuberculous drugs. There is one similar paper which has occurred quite long ago in 2017 with Keith Longer. They look at the LFTs, and then abnormal biochemistries were seen in as high as 29%, find chronic liver disease in 5.8, of which PSC was predominant primary sclerosing cholangitis, of course. But as you can see in the box here, that it did not relate to the activity of the disease, whether it occurred, whether it's a remission or whether it's. But lower panel, you can see the risk of a death was 4.8 times higher in patients with abnormal biochemistry, excluding the patients with any other diagnosis. Then what do you do? What do you do when you have an abnormal liver chemistry? First is this, to see whether they are persistent. Sometimes they can disappear after some time. Then you have to see whether it is a hepatocellular pattern or a cholestatic pattern predominantly. Left panel, you can see that how do you decide is an R factor. What is an R factor? It is an ALT by upper limit of the normal for the lab divided by ALP by upper limit of the normal for the lab. And if it is more than 5, it is a predominantly, and if it is a less than 2, it is a cholestatic pattern. But nevertheless, we never get the true patterns in our life. It's always a mixed pattern between the few. And if it is a hepatocellular pattern, one has to think of these possibilities, that is steatosis, NASH, DILI, autoimmune hepatitis, virus B reactivation, viral hepatitis, and celiac disease, because celiac disease is an autoimmune disorder, it can be associated with an IBD. If it is a cholestatic pattern, then you have to think of a primary sclerosing cholangitis, DILI again, PBC, and cheretolithiasis and amyloidosis. So respectively, you would do the investigations, and I won't go into the details. What investigations to be done for these diseases, and the autoantibodies to be done. And then the liver biopsy will be sometimes required. But then what is an algorithm? See, this is abnormal LFT, which is predominantly cholestatic, having ruled out viral infections and sepsis and DILI. Then look at the ultrasound, if it is normal, and also if the AMA2 is negative, thereby excluding the primary biliary cholangitis. Then you do the MRCP. If an MRCP is normal, you may have to do the liver biopsy for the diagnosis of a small ductal PSC. On the other hand, if MRCP suggests that it is a large ductal PSC. And if MRCP is not diagnostic, then you do an ERCP. And if ERCP shows the classical features, then it's a large ductal PSC. And if ERCP is normal, if one has suspicion still high, then one may have to do the liver biopsy. This is the course which one has to follow. Well, then, ibidologist, I know this is not the term which I have used. This is your American College of Gastroenterology have used the word that ibidologist. When ibidologist has got an abnormal LFT, you know that the prevalence of the is PSC is low in patients 7% UC and 3% TB. And therefore, the workup for existence of a PSC has to be extensive. That means it's just simply based on abnormal LFT. After having excluded, then when the ibidologist will be thinking of the PSC. On the other hand, the hepatologist, who gets the predominantly who looks at the PSC, you know that the ulcerative colitis and the IBD are quite a significant proportion, and the ulcerative colitis 48 to 68%, and less suffer from disease. But then inflammatory bowel disease related diseases have been classified into 3. One is the diseases that share a common autoimmune background, that is PSC, IgG related cholangitis, PBC, autoimmune hepatitis, and the overlap syndrome. The diseases associated with intestinal inflammation, portal vein thrombosis, Budd-Chiari syndrome, granulomatous hepatitis, and liver abscess. The diseases associated with the malabsorption or metabolic impairment, cholelithiasis, non-alcoholic fatty liver disease, and amyloidosis. But then this shows clearly which are predominant in ulcerative colitis and then Crohn's disease. The ones which are squared and the red and blue are the common for colitis and Crohn's disease, while more common for PSC and the small duct PSC are more common in ulcerative colitis and less common in Crohn's disease. Well, then this is an overlap syndromes. On the top, you got the overlap syndromes of the gut. That is an IBD with extraintestinal manifestations, IBD autoinflammatory disorders, IBD autoimmune disorder. At the bottom, you can see the overlap syndromes of the liver. That is a PSC, IgG related, and PBC and autoimmune sclerosing cholangitis. But what we are interested in, the most common, that is a PSC IBD, is the one which is the most common. The PSC IBD combo is now, there is an abundant data to support the IBD occurring in association with the PSC is a distinct form from the conventional IBD, which is not associated with the PSC. And there are some genetic background is there, but then there's no strong genetic background of overlap between the PSC IBD and then conventional IBD. There are some studies, I do agree, but they're not quite convincing, further supporting that the PSC IBD is a distinct. In a systematic review of a 31 population-based epidemiological studies, the incidence of PSC was estimated to be about 1 or so. Of course, these numbers. What is related to, what is important for us, what is happening in Southeast Asia. Here. Well, then, as I told, the PSC IBD is a very distinct disease. And ulcerative colitis is common up to the extent of 36%. Whereas Crohn's disease is about only 33%. Why it is a unique entity is that there are some special features are there in a PSC and IBD. And in ulcerative colitis, there will be no rectal involvement, there will be backwash ileitis will be there. In extensive colitis, then especially in the ascending colon, and whereas Crohn's disease is concerned, there is a less stricturing and fistulizing phenotype. And all of these would result in inflammation, and there is a very high incidence of colorectal. The ulcerative colitis macroscopically more in the right side, but frequently total in the histologically. It may be more symptomatically mild, often with a rectal sparing, but no rectal bleeding or inflammation, and it is characterized by prolonged remissions, and PSC IBD is notable for its elevated cancer. And that's what I said, that there will be neoplasia, there is a pancolitis, histologically pan, but clinically it can be only to the right side, there is a backwash ileitis, and there will be there. These are supported by all the studies which are there, as you can see, starting from 1991 to 2015, and even later, and they have seen that what are the differences between the the IBD associated with the PSC and then pure IBD without any PSC. So there's a very strong amount of data is there. The PSC IBD is a very distinct. When it comes to the pathogenesis concerned, you know that the most important pathogenesis which is coming in our way now, leaky gut, of course, it is there in everywhere, it is there in alcoholic hepatitis. The most important thing is that the microbiota, the enzymatic activity, and the associated bile acid metabolism are the ones which are. And these are I won't go into the details, but except telling that this is PSC in the healthy controls, then PSC and then IBD, and it's clearly been shown that the PSC IBD combo has got a different kind of a microbiome IBD without any PSC. And there's a growing body of literature supports that the PSC and the PSC IBD are associated with distinct gut microbiome. The more recent animal studies have suggested a potential causal relationship. Why it is important is that, the sound understanding of such a microbiome parameters in these two diseases has the potential to inform the development of a microbe-altering therapeutic. Well, I already told you about the Crohn's disease and ulcerative colitis. The prevalence of the PSC is very low, where the other hand, in PSC, Crohn's disease, and then ulcerative. What does it mean? It means that the patients of a PSC should routinely undergo a colonoscopy with the biopsies, even in the absence of symptoms. Index colonoscopy is negative. It should be repeated every 3 to 5 years. These two disorders can at different times, but IBD diagnosis usually precedes the PSC. So then what is an algorithm? Suppose if the hepatologist, when he sees a PSC patient, has to do ileocolonoscopy at the diagnosis, even if there are no symptoms, and with a random biopsies. If there is any high dysplasia or an established already CRC, then of course it's a different thing. If there is no colitis, they have to repeat the colonoscopy. If there is a colitis, that has to get added. On the other hand, if IBD patients is there for the ibidologist, Annual screening hepatic function panel, which I already told you how to go about finding out and finding the conclusion. Could be PSC by an MRCP or an ERCP or a liver biopsy for a small drug PSC. So what about malignancy? A concomitant IBD and PSC significantly increase the risk of the colon cancer, particularly in patients with the ulcerative colitis. Patients with the ulcerative colitis in the PSC are almost 5 times more likely to experience development of colon cancer and dysplasia compared to the patients alone. And this very clearly shows here, this is the ulcerative colitis alone, this is Crohn's disease alone, this is a population cohort of a PSC and ulcerative colitis. This is again a meta-analysis of 11 studies, PSC and then UC. This is of course a total IBD, they didn't differentiate, and this is a meta-analysis. What is important to see is that you see the risk here in the plain UC and then plain CD without an association. The cumulative risk is almost 10, 13, and 40 years at different stages. The odds ratio of development of colorectal cancer, if there is an associated PSC in a UC or in IBD, in fact 5 times, and then in this study about 3 times. That means that one has to be aware that the colon cancers, one has to keep an eye open. Of course, there have been several explanations are there. Again, microbiome explanation comes in the way, bile acid comes in the way. And these are all some of the explanations why the colon cancer is more. And what is the malignancy screening algorithm? Suppose if you have a PSC and an IBD, annual colonoscopy with a routine biopsy or a chroma-endoscopy with targeted biopsies, CRC, of course, colectomy, dysplasia high grade, again colectomy, dysplasia low grade, again either a considered surgical or endoscopic management with the multiple disciplinary inputs. And on the other hand, on the other side, the annual MRI, MRCP, if it is hepatic mass and then positive FISH, and then you have to manage the cholangiocarcinoma. If there are polyps, then it depends upon the size. And if they're less than 8, then of course ultrasound has to be repeated. If it's more than 8 polyps, then we have the 3 variant forms are there. One is a small duct PSC, another is an IgG associated cholangitis, and another is an autoimmune. And the association with these things with the CD is slightly less as compared. And the only thing is that in a small duct PSC, as in a larger PSC, there's an association with the ultrasound with the ulcerative colitis is quite significant. And as this one has to differentiate between IgG-related sclerosing cholangitis versus the primary sclerosing cholangitis, because it matters a lot there, because the steroids are the ultimate treatment for an IgG. Do the biopsy, then IgG4 positive will be there, IgG4 will be elevated will be there. So one has to know the differences between IgG, although it's rare, but still one has to know because steroids are very helpful. So then, as I told you, the abnormal LFT is there. What is adverse reaction to the drugs in the diagnosis? And especially glucocorticosteroids are important because the long-term use can cause steatosis and therefore NAFLD kind of phenomenon. Long-term use can also exacerbate chronic viral hepatitis, can cause a reactivation of the hepatitis B, or de novo induction of autoimmune hepatitis can come during withdrawal of a drug or with a pulse therapy. The other drugs are, of course, azathioprine, sulfasalazine, and then methotrexate. They've been associated with some. So a follow-up of these things is necessary. We know that in azathioprine, we do the TPMT and then other things. And when it comes, this is an Indian data, when it found that the prevalence of an ulcerative, the prevalence of HBV, HCV, and HIV is no different. And this is an immunosuppressing agent and relates the risk of hepatitis B reactivation. Here, yes, of course, the transplant, then rituximab comes the next, then the corticosteroids, then the TNF-alpha inhibitors, all the drugs which are used for the Crohn's disease, and last is, of course, the azathioprine 6-mercaptopurine. Of course, this has been a review of Jayanti is here. And then they have just reviewed what is happening in the Indian perspective. Although the EAMs are very high, when it comes to primary sclerosing cholangitis, it's been less frequent than in a Kerala cohort also. Ramesh is here, he can take it. This is a recent one, which is under consideration, publication, courtesy Rupa and Parthapal. Is going to be there in the gastroenterology and hepatology. This is from the consortium collected data. As you can see here that the Indonesia, 0, there is no, and North India, South India, West India, these are numbers. These 3 are numbers, not this one. Of the total 773 in North India and 4,569 in South India, hardly 3 and 14 have been found to have a PSC, and therefore, what I feel is that, I'll come to the conclusion, this concluding study, PSC IBD is a distinct entity. The ibidologist required to evaluate in depth any abnormal liver biochemistries to diagnose PSC early, although the prevalence is low, but they should have an eye open. And on the other hand, hepatologists dealing with the PSC should be aware, need to do a colonoscopy, even if there are no bowel symptoms, and need to diagnose the colorectal cancer and early cholangiocarcinoma. I think the low incidence of these is because of the asset low prevalence of PSC in an IBD. It is the hepatologist that they have to work up and then look for a PSC. Then I am sure we are going to get a slightly larger number than what we are having here. So it is the hepatologist, the gastroenterologist, and the hepatologist for dealing with the liver. They have to be sensitized and do colonoscopy every time they are suspecting a primary skin. I'm sure with that, we are going to have a slightly more, if not equal to the best, because previously, as even ulcerative colitis was thought to not to existent in our countries. IBD was also not the Crohn's disease. In fact, when I was doing the DM, if anybody diagnoses Crohn's disease, he was told that he was sure to be failed. That was the time, when the Crohn's disease was existed. Now we know that it's quite prevalent. Similarly, when we look for a the further academic part is that there is a dire need for a consolidated prospective lookout for not only for PSC IBD, for all the extraintestinal manifestations of the IBD. Thank you very much. And this is what we have to meet is a multidisciplinary approach between all the departments which we are going through now and the ibidologist. And thank you very much for your.
Thank you very much, Dr. P.N. Rao. I think the important thing for us to understand, and the message that I take from your presentation, is that awareness and collaboration. I think that is important. And I at this juncture, I would like to bring in Dr. Abhi, if I could call you Abhi.
Okay. Thank you.
Dr. P.N. Rao mentioned no case of PSC in Indonesia. I noted that. Your comments on that, your experience as far as abnormal liver chemistry is concerned in your cohort of patients with IBD.
Okay. Thank you, Dr. Ramesh. Thank you, Dr. Rao. I would like to revise. We have currently taking care of 1 PSC patients, Dr. Rao, in Indonesia. AIH overlap PSC syndromes, autoimmune hepatitis and PSC, and ulcerative colitis. Maybe for the current data, Dr. Rao, I will give it to you. 1 patient, women, 42 years old. And then for gastroenterologist perspective, thank you, Dr. Rao, for the insightful lecture. Abnormal liver tests in my practice in Indonesia is quite prevalent, but the prevalence of PSC actually is quite low. It's confirmed by latest data by Barbario et al. Meta-analysis showed that full prevalence of PSC in IBD is about 2.16%, full prevalence in worldwide. But in Southeast Asia, including Indonesia, is only 0.6% in Southeast Asia, the prevalence of PSC. So it's quite rare. And for abnormal liver tests, I agree that all IBD patients should be checked for liver function tests, the basic ones, ALT, AST, alkaline phosphatase, not only for screening for extra-intestinal manifestations or concomitant diseases, but also for baseline data for us to administer. For an example, maybe we would like to add MTX or azathioprine. So we have to have baseline data of a basic liver function test. And then regarding the clinical phenotype, I do agree with you. In our patient, the IBD, the clinical course is quiescent actually. So we have this patient. We came with to us with jaundice, obstructive jaundice from the CT scan. We perform ERCP. The ERCP is characteristics for PSC, and the CT scans incidentally detected the inflammation in the bowel. So we performed colonoscopy, but the patient did not complain any bowel symptoms, as the theory that you mentioned, Dr. Rao, before. So we performed colonoscopy, and it's confirmed that it's pancolitis, but more inflammation at the right side that's in the standing colon and cecum. So we diagnosed her also as having an IBD or ulcerative colitis in this patient. And then for the management, this is also very interesting that PSC, particularly PSC IBD, has an increased risk of colorectal cancer, 4 to 5 times higher. It's based on meta-analysis performed by Sutikno and Zhang et al. So I agree that in IBD, who was diagnosed with PSC or PSC diagnosed with IBD, we have to undergo colonoscopic surveillance annually according to the guidelines. And the prognosis of PSC IBD is worse and compared to IBD alone. And I think that's all, Dr. Ramesh, my experience of taking care of PSC overlap and IBD patients. Thank you.
Thank you very much. We'll come back to you during the course of the panel discussion because there's already one question which we have received for you. I'll come to that later. But we quickly go on to the rapid fire section of this our session today. And it is my pleasure to invite Dr. Keratic Precipitates, who's a vascular surgeon at AIG Hospitals, Hyderabad, to briefly tell us about thromboembolic complications of IBD. Does it make it an urgent problem, and how do we prevent it? Over to you, Keratic.
Hi, is everybody able to hear me?
Yes, we can see the slides.
So I'm Dr. Keratic. I'm one of the vascular surgeons faculty at Stanford University, and as part of global surgery, I've been director at AIG, taking care of vascular surgery and the needs here. A very rewarding experience. And as we say, vascular surgery is only part of our story. So we do take care of a wide range of metabolic and medical reasons as well. So without further ado, thromboembolism and increased risk in IBD. So this is just because somebody asked for an animation. This is how the clot forms when there is we all know the Vishwas triad. When there is an external injury or an inciting event, the blood clot forms and it just travels through. So in the blood, there is always a balance between the procoagulant factors and anticoagulant factors. And inflammation definitely goes towards a procoagulant by, increasing the procoagulant factors and decreasing the anticoagulant factors. So most of the times in IBD, what happens is that the inflammation so triggers that the clot forming mechanisms are elevated and the anticoagulant factors are decreased. So that tilts the balance towards forming more coagulation. So that's what we're going to talk about here. So the factors responsible for the cause of the thrombus can be broadly classified, as we all know, into 3 depending on the etiology, whether it is endothelial damage to the vessel wall, is it hypercoagulability or stasis, and these 3 headings we call as Vishwas triad. And as you can see, the endothelial damage is because of multiple reasons. But in IBD, what we mostly see is in these young patients who are admitted, mostly is seen because of stasis, and also when they're in active flare, on top of the balance being tilted towards more procoagulant, the stasis and also immobility and dehydration triggers that. IBD being an inflammatory disease predisposes patients to a hypercoagulable state, resulting in a venous and arterial So what is the mechanism of the thrombus formation in IBD? The pathogenesis is multifactorial and is incompletely understood. Unlike many other factors, the one in IBD is very incompletely understood. This has been almost found 86 years ago, the association, but yet today we don't really know what causes it. We can only speculate depending on what other factors we have. The most common cause is the upregulation, as we have talked about, of the prothrombosity and reduction. And additionally, the IBD patients also have increased platelet count, thrombocytosis during active disease, which increases the tendency of coagulation. As I spoke before, the coagulation factors are elevated and the anticoagulation factors are decreased. That's what causes the thrombus, because of the factors being tilted on the clot side. What are the facts and factors that are associated? The association has been first described by Barger and Baker in 1936. 86 years later, still unclear on strategies on how to reduce this. Specific feature is in IBD, this VTE is not seen in other pro-inflammatory factors like rheumatoid or celiac disease. This is specifically seen in inflammatory bowel disease, and specifically there is no difference amongst ulcerative colitis versus Crohn's disease. Extensive colonic involvement has been found to be an increased risk factors, most likely because of association, not merely causative factor, because the patients are found to be more sick, immobile, a lot of dehydration and everything. And the funny fact is the risk remains elevated even after a total proctocolectomy, when the confounding factors of age, sex, oral contraceptive, smoking, etc. are all removed. Still the risk remains elevated even after the surgery and even after recovery. The VTE prevalence is almost 25% even after complete recovery from surgery, which almost places these patients on par with colon cancer prophylaxis, that we have to put them on prophylactic medication even after the procedures. Arterial thrombi are very, very rare, fortunately, and these are mostly seen post-operatively, either as an MI or a stroke, which is less than 5% of the population. And most of these thromboembolic events are seen in a younger population. Mostly, again, in the distribution, we see around 30% are seen as portal vein thrombosis or cerebral vein thrombosis. The DVT occupies still, the deep vein thrombosis in the legs occupies the majority portion of these patients. And the meta-analysis showed that thalidomide increases risk of 2.6. And if you combine that with corticosteroids, the relative risk ratio goes all the way up to 8. The brief mechanisms why the steroids elevate fibrinogen and decrease TPA. Long story short, in most of these mechanisms, most of the drugs we use for IBD are procoagulant, except 5-ASA. In vivo, that it shows it has an antiplatelet effect. Unfortunately, in clinical trials and on patients in vivo, 5-ASA do not necessarily have any anticoagulant effect. Azathioprine and 6-mercaptopurine actually act with protein C resistance. So what it does is, if the patients were placed on warfarin, they would be requiring increased doses of warfarin to maintain therapeutic doses because of resistance. And methotrexate, because of elevated homocysteine and also decreased folate, causes an increased thrombotic risk factors. As I see most of the risk factors in IBD, the patients who are admitted to hospital, like any chronic patients we see, as we strive towards more zero DVT in our hospitals, any patients that are admitted in the hospitals need to get triaged as soon as they get admitted with the Caprini score and also what prophylaxis they would be requiring. And IBD is one of the most important disease that we need to find out as soon as the patients get admitted. Are they at the risk factor for developing a DVT? Should we start a mechanical prophylaxis like sequential compression devices or anti-embolic stocking, or should we put them on heparin sub-Q as a prophylactic measures? Surgeries, hospitalization, vitamin deficiencies, dehydrations. We have already spoken about the inflammation process, which makes it more procoagulant. Extensive research work showed that the patients with IBD were in hypercoagulable state owing to decreased action of protein C and protein S, and an antithrombin. Essentially, if we have to place it, the procoagulant factors are up and the anticoagulant factors are down. Research has even showed that extensive use of corticosteroids have always resulted in VTEs because of increased amount of fibrinogen. The fact is, when these patients are admitted, apart from having heparin sub-Q, if these patients can be placed on sequential compression devices, which are SCDs, which we essentially are available now, rather than the anti-embolic stockings, because the TPA gets released from the muscles every time the sequential compression devices are used. And that helps in prevention. So what is the various studies and literature that you have, and what are their interferences? The tendency of VT is found, the chance is 3.5 times more in patients with IBD when compared to the people of same age group. The tendency is as high as 6 times if the affected person is less than 40 years. Study in UK, where 17 medical conditions were studied over 2 million people, showed that IBD stands at 3rd place only after cancer and cardiac failure to be the highest cause of VTA. Even though we are focused so much on getting their symptoms better and everything, the comorbidity, the costs that are added because of addition of these VTE in these patients is significantly higher and cannot be ignored. Many studies shows the VTE in IBD patients overall stands at 3.6-fold. But if you see an individual relative risk ratio, it's 8.4 in acute attack and 6.5 times more when the patient has a chronic active condition. And even in remission, they're twice as higher to get a DVT or venous thromboembolism when compared to their counterparts. Arterial thromboembolism, fortunately, once they develop this, these are devastating effects, because most of these patients are having GI bleeding, and most of the arterial embolic events require higher doses of heparin or anticoagulation, and they end up having bleeding episodes, etc. Fortunately, they are very, very minimal, just reported in literature. In our practice in general, I do not see mostly thromboembolic events in the artery for patients with IBD, especially on the younger cohorts. So screening and treatment, we all know when they come and complain with swelling or anything, we screen with an ultrasound or get a D-dimer done. The most important take-home points for us, because most of the times when I get the question, is how long should we treat these patients? And most of them actually also have active GI bleed, low hemoglobins. How do you balance this out? So VT during active IBD without any other risk factor, we usually give 3 to 6 months of anticoagulation treatment after remission. And in the presence of temporary risk factors such as immobilization, surgery, and everything, we give at least 3 months. And on top of that, if you have congenital abnormalities, which is mostly seen in these younger populations, a lifelong or indefinite anticoagulant treatment, it has to be an individual case-based approach. But however, the guidelines are very clear on what we should do and give for these patients. So what is the anticoagulant of choice? Because these patients usually have low hemoglobin and higher GI bleeding risk. What do we do? And when a patient actually presents, say, for example, with small SMV thrombosis or portal vein thrombosis with some sort of gut ischemic factors, my go-to treatment, especially at AIG after I started, the pharmacy complains that their heparin reserves are completely down, because I very judiciously use, liberally use unfractionated heparin, because apart from, first of all, its half-life is less than an hour. It can be easily reversed with protamine, and it also has anti-inflammatory events, immediately help with the resolution of the cause and also the effect. When the 6-hourly APTT monitoring is problematic, at least I continue this for 24 hours on the floor, and then we switch it to low molecular weight heparin with wonderful results for the patients. Warfarin is absolutely not a favorite these days. We do not use warfarin anymore. And in terms of prophylaxis, if there is no contraindication and the Caprini score, as soon as they get admitted, we give them sequential compression stockings or anti-embolic stockings, encourage ambulation, and also heparin sub-Q 5,000 units TID is given, which is now given as pharmacomechanical anticoagulation. What are the newer anticoagulants? They're preferred because their action is pretty much known. They're all reversible, and they don't have to be monitored, and the action is pretty much controlled. They are either direct factor 10A inhibitors like apixaban, rivaroxaban, or endoxaban. Apixaban is your Xarelto. Direct thrombin inhibitor is dabigatran. Apixaban is a drug of choice because multiple studies have shown that this one is the choicest drug because of lowest risk of major and also non-major GI bleeding. So most of these patients, when they go home as in flare during outpatients or during inpatients, when it is preferred that there are no other procedures going on, we usually send them out on Xarelto. So the conclusion is VTE risk is very high. Prophylaxis is indicated in active flare, both inpatient and also in outpatients. If anticoagulation is contraindicated, we can give them aspirin still. Antiplatelet can be used. There is no gender or pathology influence in the risk of VTE. I was asked to keep it very short, so I hope I've achieved the goal. Thank you so much.
Thank you very much. That was brilliant. I think 10 minutes and you've covered a lot of ground on that. We will come to some discussion, except, of course, I leave you with a thought, and the question that I'm going to ask you is it time for us to say that IBD is a pre-thrombotic disorder? Because when you look at the list of pre-thrombotic disorders, IBD is not there, but the type of manifestations you had mentioned, I think it is time for us to consider that as include that in the list as well. We now go on to ophthalmology, dermatology. And we have a very dynamic dermatologist, my colleague from Aster Med City, Dr. Anuradha, who's going to talk to us about common skin presentations and when would she expect a gastroenterologist to refer the IBD case to her for skin or dermatology. Over to you, Anuradha. Welcome.
Thank you, sir. Hope I'm audible and my slides are clear.
Yes.
Yeah, thank you. So, very good evening to all of you. First and foremost, let me thank the organizers for inviting me to be a part of this brilliant meeting, the IBD ENC academic meeting tonight. So I'm sure most of you would agree that skin is a mirror of internal organs. And with respect to gut, yes, indeed, what's happening inside is many a times deciphered on the skin, and you just need to be aware of those signals and decode them to know what exactly it is. Now, coming to IBD and skin, the skin is one of the most commonly affected organ systems. The most common mucocutaneous lesions, which we see in our clinics, are Erythema Nodosum, Pyoderma gangrenosum, and Aphthous stomatitis. These findings are seen in around 22% to 75. 75 might find a little too much, but this is what the reports say. And in CD, and 5% to 11% with UC. As Dr. Ramesh said, this is going to be a rapid fire, so I'll not be going into much of the theory. This will be mostly clinical pictures to make you aware. So the mucocutaneous manifestations with IBD are basically divided into 5 groups. 1, the specific manifestations. 2nd, those associated with IBD. 3rd, the reactive manifestations. 4th, those secondary to treatment of IBD. 5th, secondary to nutritional malabsorption, which also occurs concomitantly. Now, the specific manifestations will have the same histological features of underlying IBD, and this makes us easier to diagnose it with a biopsy. So here comes the continuous and contiguous lesions, which are mainly perianal diseases, which occur in about 50% of CD. This could be a perianal erythema, abscesses, perianal complex fistulae, or even intracutaneous fistula in the abdominal scars of laparotomy or the umbilicus. So this is a perianal Crohn's disease presenting with multiple abscesses and fistulae. Coming to metastatic Crohn's disease, here we find specific non-caseating granulomatous lesions at distant sites from GIT, and these tend to occur more frequently in patients with colonic or rectal involvement. These could be, as you see in the picture, it could be an erythematous plaque, or it could be an erythematous nodule. So how do we go around this? The diagnostic approach would be, you may refer to a dermatologist, we can do a biopsy and confirm the diagnosis. Specific treatment would be, of course, surgical, apart from the control of inflammation from the GIT. Now, those associated with IBD. Here comes Erythema Nodosum, which we are all very familiar with, the most common cutaneous manifestation of IBD. This affects around 3 to 10% of UC and 4 to 15% of CD. These occur as erythematous tender nodules, mostly on the legs. These are more palpable than what we see, and these are tender as well. Then comes after stomatitis. This again is equally shared in UC and CD. It's seen in around 10%. It has a erythematous border usually. Psoriasis, another very common papilloscomus disorder. Here it's around 7 to 11% of patients with IBD, they develop psoriasis. And here's a very interesting paradoxical iatrogenic link between IBD and psoriasis, where there is development of psoriatic lesions in IBD patients treated with anti-TNF treatments such as infliximab or adalimumab. It's seen around 2% of IBD patients treated with anti-TNF agents. Epidermolysis bullosa acquisita, the name is too long, but it's a subepidermal blistering disorder with scarring. And here the antigen is type 7 collagen. And why the association with gut? Because type 7 collagen is also expressed in the basement membrane of intestinal epithelium. So this is how clinically it looks like. I'm sorry if you can't appreciate the blisters there. They are actually tense vesicles, mainly seen on the trauma-prone areas like knee, elbows, and hands. We can very well confirm it with a biopsy and an immunofluorescence study. So here again, the diagnostic approach would be biopsy if possible in many of the cases. Psoriasis, of course, clinically diagnosed unless you have a very close differential diagnosis. Erythema nodosum, yes, we need to rule out many other causes which can present with erythema nodosum. In our part of the country, it would be tuberculosis or any other bacterial infections can also present with erythema nodosum. Second, what we see usually is sarcoidosis and sometimes drug-induced erythema nodosum also. So we need to rule out other causes of erythema nodosum if you find it in IBD. And the treatment, the mainstay will be topical corticosteroids in case of after stomatitis or even case of mild to moderate psoriasis. Otherwise, it could be other immunosuppressants like azathioprine, mycophenolate mofetil, apart from the control of inflammation of IBD. Now coming to reactive manifestations. Yes, pyoderma gangrenosum, I'm sure all of you would be familiar with this. This is a debilitating ulcerative condition where it might start as a papule or sometimes a vesicle, which will very rapidly progress to form a painful ulcer. It occurs before or during IBD. So 50% of PG, in fact, have underlying IBD. In most of the cases, the IBD predates PG onset, with less than 15% of PG cases appearing before IBD. This again is a neutrophilic dermatosis, so we can actually confirm it with a biopsy. The lesions are often preceded by trauma. We call it a pathologic phenomenon where it occurs at the sites of trauma. So this is how the clinical picture will look like. That's a ulcerative lesion. This is a peristomal pyoderma gangrenosum in the second picture. Sweet syndrome. This is again a neutrophilic dermatosis where you can also have peripheral leukocytosis with neutrophilia. Again, with a biopsy, we can confirm it because you get a dense infiltrate in the dermis in this case. And it seems to be more prevalent in CD than in UC. You can also have associated features like fever, arthromyalgia, and oral ulcers along with sweet syndrome. Now, they present as erythematous tender plaques, especially on the face and extremities, more on the palms and soles. This is a particular appearance that you call it a pseudo-vesiculation. You feel that those are vesicles, but those are in fact plaques on the palms. Bowel-associated dermatosis, arthritis syndrome, where you get, this is again a neutrophilic dermatosis, you get polymorphic lesions. It may not fit into any of these distinct entities, but it could present as pyoderma gangrenosum or hidradenitis suppurativa or erythema nodosum. So this is hidradenitis suppurativa in IBD. Aseptic abscess syndrome, again an aseptic neutrophilic abscess. This is how the clinical picture would be. Pyodermatitis, pyostomatitis vegetans. Okay, here the pyostomatitis vegetans is a mucosal counterpart of pyodermatitis. Males are more commonly affected here, and these appear as vesicular or papulopustular lesions, mainly localized on the scalp, face, and even in the intertriginous areas like axillae and groins. You can have mucosal lesions as well in the oral cavity. SAPHO and PAPA syndromes. SAPHO stands for synovitis, acne, pustulosis, hyperostosis, and osteitis, and PAPA for pyogenic arthritis, pyoderma gangrenosum, and acne. These are mostly associated with UC. These are reactive manifestations. SAPHO, you can see the pustulosis on the palms and severe acne with scarring. PAPA with the acne and pyoderma gangrenosum. Leukocytoclastic vasculitis, though rare, we see palpable purpura as the clinical picture, or it could be necrotic ulcers. Palpable purpura, as you know, is a sign-kinoon of leukocytoclastic vasculitis, and this can very well be confirmed with a biopsy and an immunofluorescence. So these are palpable purpura. You can also see some necrotic areas of cutaneous small vessel vasculitis in UC. Now, coming to the diagnostic approach, most of these, as I said, can be confirmed with a biopsy, so you can always refer to a dermatologist. And treatment would be the mainstay in most of these systemic steroids. So, secondary to IBD treatment. Now, these are I'll be mostly talking about those secondary to anti-TNF agents, though many of these could arise in case of severe immunosuppression with other immunosuppressive agents. With TNF alpha antagonists, the prevalence is around 5 to 10%. You can have injection site reactions which occur in the first month of treatment, usually typically disappear in 3 to 5 days. So this does not require any discontinuation of the drug. This is an erythematous reaction involving the injection site in etanercept. The infusion reactions, it could be immediate or delayed hypersensitivity. The immediate occurring in first to 2 hours with urticarial or erythematous eruption and anaphylaxis, or the delayed hypersensitivity reaction, which can occur 1 to 2 weeks after the infusion, like the serum sickness syndrome with fever, myalgia, and rash. As I said earlier, the paradoxical reactions with TNF alpha antagonist, it could be new onset diseases in around 80%, or exacerbation of a pre-existing dermatosis, mostly in psoriasis, hidradenitis suppurativa. It could occur in lupus, dermatomyositis also. This is an adalimumab-induced psoriasiform eruption involving the abdomen and the pubic area. Infectious complications, the ECO consensus recommends not to start biological therapy during an active infection and to discontinue the treatment in case of reactivation of herpes viruses. This is a bacterial infection. It could be erysipelas, as you can see in the picture, the clear borders, or it could be diffuse when it is called a cellulitis, or it could be frank abscesses. Viral reactivation of herpes virus, the first picture, and then you can see the dermatomal pattern with grouped blisters, that's zoster. Now, those due to nutritional malabsorption, vitamin B deficiency can present with stomatitis, glossitis, or angular cheilitis. Pellagra, we can remember the 3 Ds, the diarrhea, dementia, and dermatitis with the Casel's necklace. The eczematous lesions, mostly on the photoexposed areas. Ectodermatitis enteropathica due to zinc deficiency, the acral dermatitis, and the orificial dermatitis, perioral, perianal, perigenital. Scurvy due to the, you can see the lesions in the oral cavity, the bleeding gums, the purpuric spots on the legs. So with this, come to the end of this presentation, and here's my take-home message. All IBD patients should be closely examined for skin manifestations, and dermatological manifestations, as I said, can precede bowel disease. So skin lesions like erythema nodosum, pyoderma gangrenosum, or recurrent multiple after stomatitis should alert the clinicians to evaluate the possibility of underlying IBD, so that we can have an early diagnosis and initiate an appropriate therapy. Thank you.
Thank you very much, Dr. Anuradha. A lot of interesting names, new names. Some of them, of course, will be very difficult to remember. You can now pause and gather your breath back. I think it was breakneck speed. Thank you very much for finishing off in time. The last section today, Anuradha mentioned skin as a mirror. I think now we go on to the window, and that's ocular involvement, eye as the window, and a peep into the eye, ocular manifestations of inflammatory bowel disease, and a very celebrated ophthalmologist in Cochin, Dr. Natasha Radhakrishnan from the Amrita Institute of Medical Sciences. Over to you, Natasha, for your presentation.
Good evening to all. It's a pleasure being here, and I thank Dr. Ramesh and the organizers for having me. And without further delay, we'll go into my presentation. So, is my screen visible?
It's visible, but yeah. Okay, it is full screen.
Okay. So we are going to look at some of the manifestations, ophthalmic manifestations of inflammatory bowel diseases. I have kept it as simple as possible, keeping in mind that my audience is not used to all the jargon of ophthalmologists, but I hope that sometime after this talk, you will be able to look at something that your ophthalmologist has written and make out something more than what you usually understand from it, especially because we are extremely prone to use short forms. So the incidence of ocular complications range from 4 to 10%, and it occurs more in Crohn's disease than in ulcerative colitis. And they can include anything, a whole spectrum from conjunctivitis, anterior uveitis, episcleritis to orbital inflammatory disease. We will go into this in detail. The ocular involvement may precede or follow the diagnosis of IBD. Several factors are associated with an increased risk. They say that patients with ileocolitis have an increased risk versus compared with ileitis alone. Presence of other organ involvement increases the risk, especially in patients with Crohn's disease. Arthralgia and female sex is said to be a risk factor for ocular involvement. The pathophysiology is unclear, but it is likely to be inflammatory in nature. The possibilities are that the antigen-antibody complexes from the systemic inflammation is what is inflaming the eye, or it may be an auto-antibody production, or microbial pathogens via a molecular mimicry is still under research. Genetic factors are also there because patients with extra-intestinal manifestations have a higher prevalence of HLA-B27 type leukocytes. The ocular complications we can classify into primary and secondary. Primary is having a temporal association and is associated with the systemic inflammation. Episcleritis, scleritis, uveitis, keratopathy, and optic neuritis come under this category, while the secondary arise from the primary complications or due to the treatment, like a steroid-induced cataract or a scleromalacia, or dry eyes due to hypovitaminosis A following the gut resection. Now, scleral inflammations can be divided into episcleritis, scleritis, of which the most common in IBD is episcleritis. In episcleritis itself, it may be diffuse or nodular, and in IBD, anterior scleritis is what is more common than the others that you are seeing in the list, though the others can also occur. And in the anterior scleritis, it is usually the non-necrotizing type. We will look into pictures to make you understand what necrotizing and non-necrotizing is. So episcleritis, the most common ocular manifestation of IBD is episcleritis. Episclera is a thin layer that covers the sclera, the white part of our eye. And usually in episcleritis, there will be a sectoral or diffuse congestion. And unlike scleritis, it will blanch when you press on it, and there will usually be no tenderness. It is associated with active disease and can be considered as an indicator of active bowel disease. Treatment of the underlying condition along with topical NSAIDs and steroids is the treatment for episcleritis, and it usually resolves without any sequelae. So this is what it looks like. Around the cornea, you will find a diffuse congested vessels, and it may sometimes take a nodular form as well, as you're seeing on the lower part of the screen. Scleritis is a rare manifestation, but it can cause severe ocular morbidity because it is painful, and it is quite tenderness. There will be tenderness as well. It can have peripheral corneal stromal infiltrates, and scleritis can occur even in the quiescent phase and may not be associated with activity in the gut. And you need to rule out other underlying causes if it keeps recurring, like granulomatous polyangiitis, reactive arthritis, rheumatoid arthritis, etc. Scleritis usually requires systemic steroids to suppress it. This is diffuse scleritis. It is more deeper level involvement than episcleritis. This is nodular scleritis, where you can see the large nodule on the surface of the eye. This is when recurrent attacks of scleritis makes the sclera thin and the uvea bulges out in a brown globe-shaped swelling, and that is called scleromalacia. And this is necrotizing scleritis, where you can see that the sclera has been necrosed away and you can see the underlying uvea exposed. Posterior scleritis can occur. Posterior scleritis cannot be seen, but the patient will have pain on eye movements as well as decreased vision due to an exudative retinal detachment that occurs along with it, and it can be easily demonstrated by using a B scan, in which you will see a T sign. Anterior uveitis is the next common condition that can occur in Crohn's disease, and it is a group of diseases characterized by inflammation of the uveal structures, which can be the iris and its ciliary body or the choroid. When the iris alone is involved, it is called anterior uveitis, iris and ciliary body. When the ciliary body alone is involved, it is called intermediate uveitis, and when the choroid is involved, it is called posterior uveitis. If all three are involved, it is called panuveitis. Now, anterior uveitis has a fairly dramatic presentation with blurred vision, pain, and photophobia. It can precede the diagnosis of IBD, and the most common type of uveitis among all this is anterior uveitis in IBD. Some of the patients may be HLA-B27 positive, and treatment includes topical steroids and cycloplegics. This is the classification that we follow, called the Sun classification. Now, there is something called grading of the activity. So if you send your patient to an ophthalmologist for follow-up or for diagnosis, they will tell you that there are some cells and flare. So let us look at what are these cells and flare. This is in the anterior chamber, the space between the cornea and the iris. Inside the aqueous humor, we will see white dots when we look with the slit lamp, which are basically leukocytes, and they are called cells. And grading of the activity is done depending on how many number of cells can we see in a particular subfield. And flare is the smoky appearance or the turbid appearance of the aqueous, which means that the vessels are leaking proteins into the aqueous humor. So that is the funda on cells and flare that your ophthalmologist will probably be telling you. This is fairly serious. Once the number of leukocytes increase so much, they settle down to form a white band in the inferior part that is called a hypopaeon. And these are called Keratic Precipitates. This is the most pathognomonic feature of anterior uveitis, which is leukocyte accumulation at the back of the cornea. This is again another view through the slit lamp to show you the Keratic Precipitates. This is the iris stuck onto the surface of the lens called posterior synechiae, which then causes the dilated pupil to look a festooned shape, and therefore this is called a festooned pupil. This is when the synechiae break off, you're seeing pigments that are deposited on the lens capsule called pigments on the anterior lens capsule. And of course, the cataract that we see in these patients is a posterior subcapsular cataract, can be very vision hindering, and this can be secondary to the steroid use as well as secondary to uveitis. Going to the posterior segment, these are rare complications, but I'll just quickly show you some pictures. This is occlusive retinal vasculitis, when the retinal vessels have become occluded by the inflammation and caused retinal ischemia. This is a fluorescent angiogram of the same patient, showing the extensive black areas are the areas that are not filling up because of the occlusion. After 3 months, neovascularization takes place, which can cause the patient to lose his vision. And this is extensive neovascularization in the same patient, which occurred in a matter of months. This is post-treatment, where we have injected anti-VEGF agent and destroyed the neovascularization and then lasered off the ischemic area. This is non-occlusive vasculitis, which is called exudative vasculitis. And here you can see the classical, what we call the candle wax drippings. Optic neuritis or inflammation of the optic nerve head can occur. Macular edema can occur secondary to anterior uveitis and secondary to retinal inflammation. Occlusions can occur, central retinal vein occlusions, branch retinal vein occlusions, and those are the posterior segment manifestations. Now, keratopathy is involvement of the cornea. Again, it is a rare manifestation. It can occur as epithelial or subepithelial infiltrates in the cornea. There is no visual morbidity, and it can be diagnosed by fluorescein stain, and it can be usually treated with systemic immunosuppression, and it's bilateral and symmetric. This is the peripheral corneal infiltrates that can be associated with IBD. Can you see the whitish opacification in the lower part of the cornea in these patients? And it is basically infiltrates and thinning and requires immunosuppression. The treatment of ocular complications, topical steroids and cycloplegics are the mainstay. Retinal manifestations, of course, will require specific treatment like intravitreal injections or laser. The drugs that can be used that can treat both IBD and the ocular manifestations are commonly cyclosporin, methotrexate, sulfasalazine, and infliximab and adalimumab. Now, IBD treatment can cause some ocular complications, the most common of which is, of course, systemic steroids causing cataract and glaucoma. This is glaucomatous optic neuropathy or glaucomatous optic atrophy. And you can have cyclosporin causing optic neuropathy, ophthalmoplegia, and nystagmus. Anti-TNF alpha can cause demyelinating optic neuritis. And sometimes AION and retinal vein thrombosis have been reported with the use of infliximab. Methotrexate can cause conjunctival corneal and eyelid irritation. This frightening picture is just fluorescent staining of the cornea because of the erosions that have occurred due to methotrexate. But generally, methotrexate is a very safe drug, and we often use it for uveitis in children. And after bowel resection, of course, nutrient malabsorption leads to night blindness and nutritional optic atrophy. EPN can cause maculopathy, and use of latanoprost eye drops for IOP control has been found to cause flare-up or relapse of the IBD. Latanoprost we use for glaucoma. So that reverse relationship between the ocular manifestations and IBD, ocular treatment and IBD is also been reported. This is optic atrophy following nutritional optic neuropathy. So in conclusion, the ocular involvement is IBD are varied, and some can be picked up only on a routine screening. Many of them require constant monitoring and specific ocular treatment in addition to the systemic treatment of IBD. And of course, close cooperation between the treating gastroenterologist and ophthalmologist will ensure that your patients have good vision. And I thank you all for your patient hearing. I'll be happy to take any questions.
Thank you very much, Natasha. I think the last one, a very close collaboration between the treating gastroenterologist and physician and the ophthalmologist. You said it. I think that was basically the purpose of the exercise today. 90 minutes, 5 brilliant lectures, and I think it's time for the panel discussion. Dr. Jayanti, if you could just start off while I get my thoughts together, and maybe Rupa, you could also get the chat box going. I'll first hand it over to Dr. Jayanti to start the discussion. Over to you, Dr. Jayanti.
Thank you all panelists for the wonderful session. My question was one to Dr. Karthik. How often do you find, because I think you mentioned there was no PSC in Indonesia, but how often do you find abnormal liver biochemistry in your patients with IBD? Because they can have fatty liver, they can have chronic hepatitis. So how often do you find abnormal liver biochemistry in your patients?
Okay, thank you. In my private practice, it's up to relatively high to 20%, but the cause is mostly due to fatty liver, fatty liver or side effects of azathioprine that I gave to the patients. For PSC, within 3 years, I only found one PSC. It's an overlap with AIH that currently we are taking care with hepatologists in our center. So AIH, PSC overlap, and ulcerative colitis.
Okay.
I think there's a question coming for Dr. Karthik. And I'll quickly say there's one question for Dr. Natasha. and one for Dr. Karthik. So for Dr. Karthik, the question is that there are often IBD patients who are having active bleeding. And when there is active bleeding, which antithrombotic would you recommend? I mean, this is a sick patient, acute severe colitis, choice, hospitalized patient, and what will be the drug of choice when the patient is discharged?
An extension an extension of this, most of them have microvascular thrombosis. So, would you recommend prophylaxis as a primary prophylaxis in patients with severe ulcerative colitis?
Yeah, so that's a very good question, because these are prospective randomized control trials right now going on for these patients. And also maybe we can also, with the series we have, start an exercise on scoring these patients to see, to come up with a score where we can, balance out the risks and benefits and give the appropriate anticoagulation. So to answer the first question, if the patient is actively bleeding, obviously, and we look at other factors like INR and platelet counts and everything. You can do anything from that perspective will correct the procoagulant factors. And the choice always remains heparin for hospitalized patients, because the half-life is very low, it is very controlled, and with the protamine, it's reversed in 30 seconds. So while we correct with other factors, I usually find unfractionated heparin to be more per drug of choice for patients who are hospitalized. And when they are discharged, again, for the first few weeks, it would be a Clexane or low molecular weight heparin, because it is also similar to the action in terms of unfractionated heparin, if not as much as unfractionated heparin, low molecular weight heparin. And also, it can also be reversed with protamine. The other drug of choice is Xarelto or Apixaban, because again, it has shown to have very little effect on the gut microvasculature in terms of either being procoagulant. And also, the half-life is only 24 hours and can be reversed with, even though it is not really true in terms of pharmacomechanics, giving FFP will also benefit for those patients who are on Xarelto, though we don't really see on the mechanism of action for some reason, because obviously the fresh frozen plasma is everything. In terms of microvasculature and prophylaxis, as I said, the randomized control trials are going on. As of now, unless the patients had a prior DVT, we cannot recommend patients to be on prophylaxis before an event occurs. We can actually look at their D-dimer levels while they're admitted in the hospital. And if the Caprini score, which we usually use for any patient at an increased risk factor for DVT, we apply that to IBD patients as well, and we give them both pharmacological prophylaxis and heparin sub-Q. There's an interesting study where they have shown, in fact, the amount of DVT in patients that are admitted under surgical service during the active flares are prone to have less amount of DVTs than the ones which are admitted under medical services, because the very fact is the surgery, especially in the Western world, because the surgical services usually, as a matter of fact, in their order sets have a DVT prophylaxis for all of their patients, and that's most of the patients have heparin sub-Q, and that is now actually given to the medical side as well, where these patients, if there is no contraindication, adding a heparin sub-Q 3 times a day, giving a smaller injection, 5,000 units, just subcutaneous, is more than enough for most of these patients. But they don't necessarily have to be sent out unless they had surgery for prophylaxis. I hope I answered the question.
Dr. Raja, do you really do this in Malaysia? I mean, for all your active colitis patients, are you giving prophylactic thrombolytic therapy?
Thank you, Dr. Rupa. A very important question. I got somehow, for the last 3 years, many patients, I got, I think, more than 12 from cavernous sinus thrombosis to the digital thrombosis, leading to the surgical intervention and even digital amputation. Now, I think we really have to understand that a sick patient in the ICU setting or high dependency unit, as Dr. Karthik said, that unfractionated heparin is very useful simply because of reversibility, combined with the TEC stockings, thromboembolic deterrent stockings. Now, first episode where the VTE, the lung, or huge clot in the lung that necessitate lifelong thrombosis. But I think I have a very bad experience for the last year or so. A lot of patients that I give the NOAC or DOAC, novel or dual antithrombotic, in the setting of by the time they're going to discharge, in which the albumin is still low, suggesting that malabsorption is still going on. And if we give oral anticoagulant, it may not be effective. They may be coming back with episode of thrombosis. So leading me to change them to use the low molecular weight heparin. So I got 3 bad cases as well. The use of NOAD and DOAD that got massive bleed from the deep ulcers of colonic Crohn disease. Really scary because leading to embolization by the interventional radiologist. I'm not sure the exact etiological of that for a 5 patient really using DOAD NOAD. So really give me a bit cautious to use the novel DOAC or NOAC for a patient get thrombosis either for 3 to 6 months or even a month or so. And I really closely liaise with hematologists, and they actually prefer low molecular weight heparin because of malabsorption and multifactorial factors for the outpatient management of thrombosis. Dr. Rupa.
Could I come in now? You had a question for Natasha, Rupa. You could complete that and then I'll come.
I'll quickly do that. So Dr. Natasha, the question is this: is there any eye complication? Because we understand the importance of the eye, and though we've seen all your pictures, I don't think we would be able to diagnose between episcleritis and scleritis right as we see the red eye. So is there any alarm symptom by which the gastroenterologist should immediately send the patient to the ophthalmologist in a matter of hours, and it will make a difference? Because there are some situations where we will just say that, okay, you need an eye consult, and there will be some where we need to see that in the next hour you should meet. Is there any such ocular emergency?
Yeah, I would not say there is an emergency, but there are some of the, and unlike the other set of diseases in which we collaborate with another department is the rheumatology department. Just to give you an example. For them, their kids, like when they have juvenile idiopathic arthritis, they also have uveitis, and unfortunately, those set of children do not have any symptoms. So luckily for you, gastroenterologists, the uveitis and eye involvement in this group of children and adults is extremely symptomatic. So all you have to do is to listen to your patient. If your patient tells you that he has redness, he has pain, or he has decreased vision, of which redness would probably be lower down in the list in terms of emergency, but if he has pain in the eyes, pain on movement of the eyes, or with decreased vision, you need to refer to the ophthalmologist. But thankfully, none of these are like screaming emergencies. You don't have to wake the ophthalmologist from the bed. You can wait for the next day, and probably within a few days, they need to get help. But of course, uveitis can get worse in a few days. So as early as possible would be fine, but
because
not a casualty.
Loss of vision is noted, so I suppose that is why the question.
Yeah, any sudden loss of vision in your patient, I think you better not take a risk. It could be some vascular occlusion. It could, I was just listening to the question before, it could be cavernous sinus thrombosis. So let's just refer if there's decrease in vision. Sudden loss of vision should be an emergency. Everything else, pain, redness in the next OPD would be fine, but as early as possible.
Rupa, I learned one thing from my ophthalmologist. Episcleritis, painless, can be self-resolving. If the patient coming with pain, just refer to ophthalmologist to look after. That's all. Correct. Pain, eyes, just refer.
Correct.
Very, very simple take-home message. Now, question to Dr. Amita. You have, during your course of the presentation, I was actually looking forward to hearing from you about the use of small molecules. Rheumatologists are much bigger users of small molecules than the gastroenterologists. But your presentation was a bit silent on small molecules. Do you think that these small molecules have an important role to play in patients with rheumatological complications?
As I said earlier, that arthritis, what you see in IBD, as the other person also said, that generally it resolves once your bowel disease is taken care of. Or the drugs which we are using for bowel disease, they are also immunosuppressive. So they also take care of the peripheral arthritis which individuals have. It's only the axial disease which has actually hardly any relationship with the bowel disease, which needs to be managed. And their anti-TNF agents are really good. And need for jackknips is much less. And I feel in our country, the jackknips are being misused rather than being used. Because once they have become generic, even patients with osteoarthritis are now getting JAK inhibitors and coming to us once they find they are still expensive for this kind of a knee osteoarthritis where they didn't need any drugs at all. So I feel that the need is very limited. And if it is needed, it should be done under supervision. You should send to the rheumatologist, have an opinion. Does this patient require to take jackknips for the joint manifestation? You may use it for Crohn's disease. People are using, there are studies to suggest that they have beneficial effect in inflammatory bowel disease also. But for arthritis, very limited data.
I think a very strong word of caution, because I remember my first patient on tofastinib came back with chickenpox and I was quite embarrassed with that. Likewise, a word about salazopyrin. Now, that is a favorite as far as rheumatologists are concerned. The use of salazopyrin in patients with peripheral arthritis or spondyloarthropathy, complicating it.
The thing is that sulfasalazine has a little bit gone down the line now. It used to be a drug which used to be used very often when I trained, because we had very limited armamentarium of drugs. But it's very useful. You have chronic disease and you have peripheral arthritis because it works on both the systems. And obviously a patient wants to have a wholesome treatment and work on both bowel and arthritis. The problem is, one, occasional patient can have severe sulfa allergy. The second, pill burden is still significant because you have to take it twice a day, which patients, younger age group patients don't want to take. So that is why methotrexate has really come up in a big way, because it's once a week therapy. Its toxicity profile is also probably better than sulfasalazine, except in patients who want to have pregnancies. Their methotrexate is contraindicated and sulfasalazine can still be used in young women. So the use, what I would say, it has absolutely no effect on the axial skeletal disease. So for axial arthritis, enthesitis, its role is very, very limited. It's only useful in peripheral arthritis, predominantly arthritis, which is lower limb arthritis, and chronic, not for.
Okay. We move on to Dr. P.N. Rao. Dr. Rao, you mentioned in passing about granulomatous hepatitis in patients with Crohn's disease. I take you back to the days when granulomatous disease was almost always tuberculosis unless proven otherwise. Even today, a lot of people believe in that. But what is your opinion? Do you see granulomatous hepatitis because of Crohn's disease? And how do you actually differentiate?
No, even in the existing literature also, the granulomatous hepatitis as a manifestation of the Crohn's disease has been very small. In fact, there will be no necrosis will be there, and therefore you can differentiate, and they are microgranulomas. And mostly they are picked up at a biopsy rather than in the symptomatic. They don't have any symptoms. When you do the biopsy, then only you pick them up. It doesn't have any clinical relevance, basically, actually.
It doesn't.
Either the influence of the course of the disease on IBD or on the other side.
I think I to add in over there, I think in the liver, if granulomatous hepatitis is very rare, what we are seeing now is increased NASH or fatty liver in IBD patients, and we are not really screening all the time. So I think, Dr. P.N., if we can have your comments on that, should we routinely screen for it? And once again, I mean,
And just like in general population, is a NAFLD is in the increase, diabetes is in increase, and you have already the risk factors for the development of diabetes in these people, and also obesity in terms of your glucose. Right. And therefore, and then even in the some analysis have been done, NAFLD is one of the commonest abnormalities, persistent abnormalities of the liver biochemistry. And screening, of course, ultimately what do you do again?
So
it is only lifestyle modification.
Would it be right for me to say that almost 80% of the liver chemistry abnormalities that occur in patients with inflammatory bowel disease are not linked directly to inflammatory bowel disease?
Correct.
It is totally unrelated to inflammatory.
Correct.
Okay,
Absolutely.
Very. The other thing that you made mention was reactivation of hepatitis B virus in patients with inflammatory bowel disease. I think that also holds true with any other system of part of medicine, be it rheumatology, dermatology, people who are put on immunosuppressants. How often in our country do you see this problem of reactivation?
And then reactivation we've been seeing mainly with the rituximab, in people who've been treated with the lymphomas, lymphoproliferation. As already told that we find that there is no increased prevalence of the hepatitis B or HCV in patients with the IBD, but nevertheless, when you want to start an immunosuppression, it's mandatory to do HBsAg before starting as a baseline investigation. And anti-HBC also to do. If HBsAg is negative, anti-HBC will guide you that he had a previous infection. Then one may have to do HPV DNA before starting the steroid. And a small dose of steroid is enough. 20 milligrams itself is considered as a slightly bigger this one, because we use in autoimmune hepatitis for 40 milligrams of dosages, whereas in inflammatory bowel disease
I think we could also hear very quickly, because we have about this chronic hepatitis B reactivation before immunosuppressants and on from Dr. Abhi and what is happening in other parts of the world as well.
Dr. Abhi, please.
I think she has to repeat, some words,
I'm sorry, Dr. Rupa, because you are freezing.
Dr. Rupa said that hepatitis B reactivation is something that is seen in not only in this part of the world, in the Far East as well, and probably more common there. What is your experience with hepatitis B reactivation on patients in whom you start immunosuppression?
Okay. In our hospital, all IBD patients before undergoing immunosuppressive therapy, we always regularly check for HBsAg, HBeAg, and LTST, Dr. Rupa. So we always screen for hepatitis B. So we haven't found any reactivation, because before administering those immunosuppressant, we actively screen for the hepatitis B. And if it's detected, we always consult our fellow hepatologists, and they will give antiviral before we are giving immunosuppressant or biologic agents. So we don't have any experience of Hep B reactivation in IBD patients, because we are actively screening for Hep B.
Very close
I think vaccination is important. Vaccination is important.
We have close collaboration with the hepatologist in our hospital.
I would like to bring Anuradha into the picture now. A question and a comment. Local or topical tacrolimus is quite often used for patients with pyoderma gangrenosum. Does it mean that this should have a bigger role to play in the management of IBD, tacrolimus? Do you have any experience? And the comment is, of course, our recent case, which I would like to highlight, a patient who was on infliximab, had a skin lesion. We referred to Dr. Anuradha. He did a biopsy. By that time, the patient went because he wanted to go to another hospital, but the biopsy came back as cutaneous tuberculosis. Anuradha, a few words on that case about from you. That
Yes.
was very interesting.
Yeah, regarding the first part of the question, pyoderma gangrenosum and topical tacrolimus, I would say topical tacrolimus alone will not work. It is usually a supplementary, or you may call it an adjuvant therapy. You usually need oral corticosteroids, or mycophenolate mofetil is what we use along with corticosteroids for pyoderma gangrenosum. Topical tacrolimus alone usually does not work. It can be a good adjuvant, but not alone. Now, coming to the second part, regarding the case, yes, it was very surprising to see the report as tuberculosis, but unfortunately, we couldn't have a follow-up with the patient. It could be because of the immunosuppression, or tuberculosis for that matter in our part of country is rampant. It can occur in anybody and everyone here. So,
but I think that case had a very important message,
yes.
and
Yes.
I thought I should highlight it
Sure.
in this forum, because that is one of the possible side effects. Over to you, Rupa, for your remarks, and then Jayanti for her concluding remarks, because I think a lot of things have been covered, but I think what I'm left with is the initial message which Dr. Amita gave. When do you suspect that a patient with arthritis could be having IBD? And I think that was a very important slide, and
I think
still
we'll ask
remember that.
Dr. Raja for commenting on that. When would you really think a patient with joint pains, and how would you proceed? Just for our postgraduate watching, what would be the steps?
Thank you so much, Dr. Rupa and friends. I think, first of all, ourselves and colleagues like rheumatologists, dermatologists, we really have to think outside our box, outside our specialty. For example, now, for the last 4 years or so, I'm getting more common for my rheumatologists sending fecal calprotectin, even though their patient present only loose stool rather than typical diarrhea that we see in the clinic. But from our side, patients who presented with typical GI symptoms, and then we do the workout, usual blood markers and fecal calpro and endoscopy and biopsy and typical either Crohn's or UC. When we start the steroid, the joint pain disappear automatically. But on the other hand, if the patient goes to the rheumatology with the joint pain, very least likely they will complain about the GI symptoms unless been asked many times by the rheumatologist. Or unless in the clinic also, we as a gastroenterologist has to be open-minded, asking head to toe symptoms rather than purely how many bowel motion, bloody or non-bloody, you know, the painful red eyes, skin rashes, and in fact, many of the aspects that we shared about psychosexuality and mental health, especially during the COVID. You know, one of my patients killed herself because of loss of job, plus also moderate active disease that we are ignored. So I think working together is a fun, and we always complementary each others. And simply, if I were hoping that rheumatologists sending routinely fecal calpro, which is costly to the patient, slightly elevated, and you take the biopsy, the pathologist said non-specific colitis, what are we going to do? Nothing. So I think it has to be case-to-case basis. We don't treat the disease, treat the patient as a whole, and work on that. And I think that's the way it should go. And the patients are getting clever nowadays. Patient can use a lot of Dr. Googles before coming to you. So I think, or coming to me, and I think we do not want to over-investigate as well. We don't want to use the artificial intelligence replacing our intelligence. I think we have to have a really human touch, good history taking. We know that from the past, where with students, 80% of the diagnosis are coming from the history and physical examination. Only 20% coming from what? MRI, small bowel, ultrasound, fecal calpro. So we basically diagnose already in the clinic without doing or spending a lot of money. That's the message, Dr. Rupa.
How right you are. We are often at the mercy of Dr. Google, when these patients come to us. And but I do see, and I think Dr. Amita would probably agree with me, that there is probably a bigger role of fecal calprotectin in our approach to patients with maybe a peripheral arthritis or maybe a uveitis or episcleritis going to the ophthalmologist, or maybe skin lesions going to Dr. Anuradha. But I think, yes, we must learn to watch and see the patients as a whole rather than focus on our own specialties. And today's session has been precisely that. And with this, I think
Dr. Ramesh,
yeah,
can I just share the pitfalls when the rheumatologist is sending the fecal capro, because a lot of their patients taking NSAIDs, and NSAIDs are really cause slight elevation of fecal capro and leading to unnecessary colonoscopy. So we have to be a bit careful.
Let me come in at this time, because
Dr. Amita, yes.
I don't think a rheumatologist would order a fecal calprotectin in every Tom, Dick and Harry. So when do we think, as I said, when do we think of IBD? IBD is thought of when you have a patient who has symptoms which are like peripheral spondyloarthropathy and has anemia out of proportion, or has weight loss out of proportion to the symptoms, or the degree of inflammation. That is a time when we think of it. You won't like to do as what Dr. Raja said. Fecal calprotectin can be increased in many other conditions. Even a non-specific colitis can give you an increase in fecal calprotectin. NSAID use can give you a fecal calprotectin. So it's not a test which should be ordered every day in every patient. Should be done when you have a high index of suspicion. Before you want to do a colonoscopy or another procedure, you see for fecal calprotectin.
Great. So I think we have run out of time. Half an hour for discussion was what we had kept, and we've run out of that option as well. It was a great discussion.
Dr. Rao, you want to comment something?
No. I just wanted to ask Rupa, what is the family history in these people in your large experience of IBD which you have collected so far? Sometimes that may indicate family history. That means that other family members having either a Crohn's disease or ulcerative colitis or vice versa.
So we've actually published this just recently in intestinal research. I think our family history positivity is around about 4% average, ranging between ulcerative colitis and Crohn's disease. What we find is direct parent to child is even lesser. It is around 2%, and this is a database of more than 4,500 patients. And there is more amongst cousins, but those with a family history seem to have a little more severe disease. So it's different from the Western world. That is most important, because they report 20%, and this is what we have gone into in great depth because of our database, and it is not that way. So when counseling patients, it is very important to tell that in this part of the world, even in the IBDENC group, the data of 10,000 patients, we are not finding a high family history. So for counseling purpose, we can always tell patients.
The reason I asked is that even that one also may not help to routinely do the calprotectin in other diseases.
Yes.
That's the reason why. If that was high, then there could be some small indication. Right, over, Rupa.
Okay. Dr. Jayanti.
Dr. Rupa, you want to comment on your next meet?
Yes, so we'll just, I think this has been very educative for us gastroenterologists, and I must first say that, and the slides, so Dr. Jayanti, for your closing remarks, and we will show you the next upcoming program as well, and of course our sponsors, the slides will be coming in.
So on behalf of Vibrant course director Dr. Rupa and my co-moderator Dr. J. N. Ramesh, I wish to thank all the panelists for the wonderful session in taking us across the spectrum of various allied specialty in IBD pathology as Dr. P.N. Rao put it. And thank all the delegates for attending the session, and have a wonderful day. Over to you.
So our next session is on the 25th of February 2022, the full spectrum, fistulizing Crohn's disease. We'll keep you updated, and I hope you'll enjoy it as well. No conference, no meeting can end without thanking profusely our academic partners. We have Janssen, Dr. Reddy's, Microlabs, as well as Takeda. Thank you. Thank you for your help and academic partnership.
Thank you very much to all the speakers, Dr. Amita, Dr. P.N. Rao, Karthik, Dr. Karthik, Dr. Anuradha, and Dr. Natasha. That's great. And especially to our guests, or to our faculty from outside of India, Dr. Raja and Dr. Ebi. It was wonderful interacting with you. I think a lot of important messages which we go back with, and now looking forward to the next meeting where we look at fistulizing Crohn's. Rupa, thank you very much. Jayanti, thank you very much. Good night to you all.
Thank you very much, Dr. Rupa.
Thank you and good night.
Thank you.
Good night. Good night. Thank you.
Thank you.
Very nice meeting all of you. Thank you.